Hello and welcome to the Total Knee Replacement Preoperative Education presentation. The goal of this presentation is to answer some of the questions you may have about your upcoming surgery. This presentation is intended for patients scheduled to undergo knee replacement surgery or those considering total knee replacement. We recommend you to have a pen and paper nearby to jot down any questions that may arise. It can be helpful to bring this list of questions with you to your preoperative appointment. A total knee replacement is also known as a total knee arthroplasty. The implant replaces the damaged area of the joint, allowing the patient to regain function of the knee joint. In the U.S., more than 600,000 TKRs are performed annually. Here at Scripps Green, more than 1,000 knee replacements are performed each year. Total knee replacement has a national success rate of 90%, and here at Green Hospital, we have a success rate of 94%. A successful knee replacement is one where the patient is satisfied with the outcomes in regards to pain and stiffness, the implant is stable and working well, no further knee surgery is required, and the patient is able to return to normal daily activities. How do you know when you should consider knee replacement surgery? The most commonly reported pain complaint is progressive joint pain and stiffness. The pain and stiffness can be moderate to severe and limits everyday activities and can interrupt sleep. Performing simple daily activities such as tying shoes, getting in and out of a car, and even walking can become difficult tasks. You most likely will have had an X-ray that confirms damage and loss of joint space. In the beginning or mild stage of the disease, conservative measures such as oral pain medication, cortisone injections, physical therapy, and activity modifications may provide relief, but as the disease progresses, these conservative measures no longer provide relief. The goals of knee replacement surgery are to relieve pain, increase level of function, improve the appearance of the knee joint, increase motion and strength, and most of all, improve quality of life. So what causes damage to the knee joint? There are three types of disease that cause degeneration of the joint: osteoarthritis, inflammatory arthritis, and avascular necrosis. Osteoarthritis is the most common cause. It is important to know that no matter what the cause, treatment is the same. Osteoarthritis is associated with aging and is referred to as wear and tear arthritis, usually seen in patients over the age of 50. Other causes include genetic disposition, previous trauma, previous joint infections, previous joint surgeries, occupation in sports that were rough on your knees, and prolonged obesity. Pictured here is an example of a healthy knee joint. The knee joint is made up of the lower part of your thigh bone, called the femur, the upper part of your shin bone, called the tibia, and the kneecap, called the patella. The ends of the bones are covered in a smooth substance called cartilage that allows for smooth movements. In addition, there are cushioning pads called menisci that act as shock absorbers. Ligaments and tendons complete the structure of the knee. This is a picture of what an arthritic knee joint looks like. There is little to no cartilage left and bone spurs present. You can see why this would be painful when articulating back and forth in a walking motion. The knee implant is made up of three major parts: the femoral component, the tibial component, and the patellar component. The parts of the implant are made of different metal alloys and polyethylene plastic. Your surgeon will discuss the best implant for you. The first step in the knee replacement involves preparing the femoral surface. The damaged areas are removed and a femoral component is placed onto the femur. Next, the damaged surface of the tibia is removed and the tibial component is attached. A plastic spacer is inserted between the metal components to create a smooth surface. The metal parts are press-fit into the bone to allow the bone to grow into the implant, in addition to using cement. Lastly, the patellar surface is removed and the patellar component is attached to create a smooth gliding surface between the femoral component and the patella. A unicompartmental or partial knee replacement can be used in some cases where the arthritis has only affected one side of the knee joint. The same materials are used. Your knee incision will be closed with either staples or Dermabond, which is a surgical glue. The type of closure is decided by your surgeon based on the surgeon's preference and patient anatomy. This will be discussed with you at your preoperative appointment. It is common for all incisions to be itchy, swollen, and bruised after surgery. These symptoms will resolve on their own in time. Caring for your incision depends on what type of closure was used, and you will be instructed on caring for your incision at your preoperative appointment and again before you leave the hospital. All incisions should be iced throughout the day, kept clean and dry, and creams and lotions on the incision should be avoided for the first 4 to 6 weeks. If you are experiencing drainage or fluid coming out of the incision, increasing redness, fever of over 101 degrees, or pain unrelieved with rest and medications, you should contact your surgeon's office. As with any major surgery, there are risks associated with total knee replacement. Infection, blood clots, and early loosening of the implant are the most common. Other less common risks, such as nerve injury, bleeding, and fracture, can occur. We will focus on the 3 most common risks in the next few slides. Infection prevention is one of the major goals before, during, and after surgery. We recommend all surgical patients begin using a surgical wash, called HibaCleanse, for 7 days prior to surgery, washing your entire body from the neck down, paying particular attention to your surgical incision site. This soap will be provided to you at your preoperative appointment. All patients are screened for staph bacteria, referred to as MRSA or MSSA. This is done by swabbing the nasal area at your pre-op appointment. If your nasal swab is positive for this bacteria, you will be treated with an antibiotic ointment to be used prior to surgery. Operating rooms for total joint replacement surgeries are equipped with laminar airflow. This type of airflow design provides uniform, directional airflow that moves floating particles away from the surgical area to prevent contamination. In addition, the staff members working in the operating room will wear protective, airtight suits in the operation to further prevent any contamination. All patients will receive intravenous antibiotics during and after surgery. Dental work should be avoided for the first 3 months following joint replacement surgery. Once you resume dental care, you will require oral antibiotics 1 hour prior to all dental procedures. Antibiotic prescriptions can be provided to you by your surgeon's office or by your dentist. It is recommended that you inform your dentist's office as soon as possible that you have an artificial joint. Blood clots are another major risk factor of knee replacement surgery. Blood clots can form in the veins in the legs and can become life-threatening if they break off and travel to your lungs. The best prevention is moving frequently and as soon as possible after surgery. While hospitalized, you will wear mechanical leg pumps that will help pump the blood in your legs while you are in bed. In addition, medications are needed to thin your blood after surgery. Most patients will go home on a baby aspirin twice a day for 4 to 6 weeks. If you are at a higher risk, meaning you have a history of a blood clot, active cancer, and are already on a blood thinner, you may be prescribed a prescription-strength blood thinner such as Lovenox, an injectable, Coumadin, or Xarelto. The type of blood-thinning medication you will be using will be decided by your surgeon and discussed with you at your preoperative appointment. Over time, knee implants can wear out and loosen, requiring revision surgeries. Just like hardware on a cupboard door, the better you treat it, the longer it will last. We recommend avoiding high-impact activities, such as running and jumping, on a regular basis. If running is your cardiovascular activity of choice, changing that to riding a bike or an elliptical may increase the lifespan of your implant. It is also recommended that you use caution when taking part in high fall risk activities, such as skiing, horseback riding, and surfing. In addition, avoiding uneven surfaces to prevent falls is also very important. Keeping weight in a healthy range will also protect your new knee implant. Acceptable low-impact activities include walking, use of an elliptical, use of a stair climber, biking, swimming, slow dancing, and golfing. We recommend that you wait at least 4 weeks for any water submerging activities and 6 to 8 weeks for activities that require pivoting movements such as slow dancing and golfing. Preparing for surgery is very important. If you smoke, it is highly encouraged to quit smoking as soon as possible. Smoking leads to delayed wound healing and increases risk of blood clots and infection. It is important to note that all Scripps campuses are smoke-free. All dental hygiene needs to be completed at least 4 weeks before your surgery to decrease the risk of infection. Some surgeons may actually require a dental clearance. It is also important to think ahead and arrange for assistance at home, whether it's a family member staying with you or a friend checking in on you to help with meals and transportation if needed. One might find quad strengthening, if tolerable, prior to surgery beneficial in the recovery period. Preparing your home is also important. Clearing clutter from walking paths, removing loose rugs, having commonly used items in reach, and good lighting is also recommended. If you do not already own a front wheel walker, you can borrow one from someone you know, or one will be provided to you upon discharge from the hospital. Prior to your surgery, you will have a day of preoperative appointments. These appointments include a history and physical with the surgeon's nurse and assistant surgeon. It is very important to bring a detailed medication list with you to the appointment. All medications and supplements with dosages need to be reported at this time. You will also meet with a pre-anesthesia assessment teaching nurse, where anesthesia risks will be discussed, medication instructions will be given, and lab work, EKG, and nasal swab will be performed. Your final stop will be with the hospital admissions department to verify insurance details for your procedure. During your preoperative appointment, the anesthesia nurse will instruct you on which medications to stop prior to surgery and which medications to take the morning of surgery with a small sip of water. Common medications to stop before surgery because they thin the blood include aspirin, Plavix, Coumadin, vitamin E, fish oil, herbal medications, and anti-inflammatories. Please note, if a physician put you on one or more of these medications, you will need to seek clearance in order to stop them. All patients are instructed to stop eating and drinking after midnight prior to surgery, with the exception of certain medications. Again, you will be instructed on which medications are to be taken at your preoperative appointment with the anesthesia nurse. If you are diabetic, it is important to know that blood sugar levels will run higher after surgery due to stress on the body. While hospitalized, all diabetic patients will receive insulin for blood sugar control. Once home, patients can resume their usual diabetic regimen. Everyone will undergo a general anesthetic, meaning you will be asleep and unaware of any pain. In addition to the general anesthetic, you will receive a local nerve block that helps with pain control following surgery. In some cases, a spinal may also be used. You will be evaluated the morning of surgery by the anesthesiology team to determine which type of anesthesia will be used. A nerve block may be offered to you the morning of surgery by your anesthesiologist. The nerve block decreases sensation to the nerve that runs down your leg to provide additional pain relief after surgery. The nerve block helps keep you relatively comfortable for a period of time following surgery to allow for oral pain medication to take effect. It is important to call for assistance to ensure your personal safety. Again, you will be instructed not to eat or drink anything after midnight the night before surgery unless instructed to take essential medications. On the day of surgery, we ask that you arrive 2 hours prior to your surgery time. Check in at the information desk at Scripps Green Hospital. Family and friends are instructed to wait in the surgical family waiting area on the first floor of the hospital. After the operation, the surgeon will meet with family and friends to discuss the details of the surgery, or they may leave contact information for the surgeon to call them after surgery. You should bring a photo ID and insurance card with you, along with a detailed medication list. Cell phones and laptops are allowed, but Scripps is not responsible if these items are lost or stolen. It is best to leave these with your family or friend until you have a room assignment following your operation. If you use a CPAP or BiPAP, please bring your mask with you. Please do not bring valuables or medications with you unless you have been instructed to do so. Your operation will take about 2 hours. After that, you will be taken to the recovery room until you awaken from anesthesia, pain is controlled, and you are stable. This can take anywhere from 1 to 2 hours. Once you are awake, you will be taken to the post-operative care unit on the 4th floor for 1 night in a private room before going home. Most patients are going home the day after surgery, but occasionally someone might require a second night stay. Pain management is a major post-operative goal. Pain will be present, but varies depending on the individual patient. Pain is rated on a scale of 0 to 10, where 0 is no pain and 10 is the worst pain imaginable. The goal during the post-op period is a pain level of 3. There are multiple modalities available for pain control, including narcotic pain medication, anti-inflammatories, and even steroids. It is important to always communicate your pain to the nurses and surgeons and be an active participant in your care so we can modify our treatment to make sure you are as comfortable as possible. During your hospital stay, you will have daily blood draws to monitor your blood count. Staff will help you change positions to keep you comfortable and prevent areas of pressure on the body while in bed. You will also be instructed on the use of an incentive spirometer to keep your lungs expanded and prevent pneumonia. You will have pumps on your legs to keep blood moving. Your diet will be progressed slowly to prevent nausea after anesthesia until you are ready to resume to your normal diet. You will also be visited by a physical therapist twice a day. During your hospital stay, you will participate in physical therapy twice per day, beginning on the day of surgery if you arrive on the postoperative floor before 4 p.m. The physical therapist will instruct you on gait or walking, getting in and out of bed, stair training, and a home exercise program. It can be helpful to have a family member or friend present during the physical therapy session for therapy reinforcement at home. The major focus of physical therapy following total knee replacement is range of motion by performing flexing or bending of the knee and extending or straightening the knee. The physical therapist will guide you on the normal range of motion goals, which is measured in degrees. Before you leave the hospital, you will meet with the hospital case manager, whose role is to assist in preparing a safe discharge from home to the hospital. This nurse will work with you, your insurance, and your medical team to arrange a home physical therapist if indicated, and any medical equipment needed for home use, such as a walker. If it is determined that you are a candidate for a skilled nursing facility before going home, the case manager will arrange this as well. As stated earlier, most patients will transition home after 1 to 2 nights in the hospital. What determines readiness for discharge home are the following criteria: getting in and out of bed independently, walking 150 feet safely using a walker, pain managed by oral pain medication, and ability to perform daily activities such as dressing and using the restroom on your own. If indicated, a home physical therapist will be arranged for you. The therapist will make visits to your home 2 to 3 times weekly for 2 to 3 weeks, or until you are deemed safe for outpatient therapy. Your insurance will decide how many home visits you are eligible for. Please bear in mind, if you live in remote areas of the county, such as Julian, Jamul, Palm Desert, or Borrego Springs, there may not be a home health agency serving your area. In this case, you will transition directly to outpatient physical therapy. If staples were used on your incision, a trained home physical therapist will remove your staples 10 to 14 days after surgery. You will see your surgeon for your first post-op visit, roughly 4 to 6 weeks after surgery. A skilled nursing facility may be recommended if one is slow to progress with physical therapy, unable to perform basic personal care like going to the bathroom on your own, and/or have medical needs which require skilled nursing. Living alone, having no one home to care for you, having a disabled spouse, living in a 2-story home, or being of advanced age are not risk factors in determining eligibility for nursing home placement. Insurance coverage varies, and daily copays and what facilities accept your insurance varies. If you think you may be a candidate for nursing home placement, we highly encourage pre-surgery visits to nursing homes covered by your insurance. Please note that nursing homes will not reserve beds in advance. The case manager in the hospital will check insurance coverage, make your reservation, and arrange transportation. We strongly believe that patients recover better at home in a familiar environment where exposure to infection agents is low. If you do not have help at home, you may consider privately hired assistance. Constipation is a common problem after surgery due to anesthesia, pain medication, and reduced physical activity. We recommend the outline program at home to prevent constipation: a high-fiber diet and increased fluids, over-the-counter stool softeners 2 to 3 times a day, and a mild laxative daily, such as Miralax. If these measures are not effective, a stronger laxative such as milk of magnesia or bisacodyl may help. If it has been more than 3 days from surgery without a bowel movement, we recommend glycerin suppository or enema for quick relief. Always follow label instructions for each product, and stop the bowel management program when normal bowel function has resumed. For ongoing bowel problems, contact your primary care doctor. After surgery, you may experience some or all of the following: decreased stamina for 8 to 12 weeks, decreased appetite for several weeks. If you are having difficulty eating, we recommend drinking protein-packed beverages, such as Ensure or Boost. Your balance and concentration may be off, which can be related to pain medication. And you may have difficulty sleeping for several months. You will not be driving to 3 to 6 weeks based on your surgeon's recommendation, and you will set off metal detectors. There is no documentation needed for airports or local federal buildings. Places that do require documentation are state prisons and federal buildings in Sacramento and Washington, D.C. If you know you will be visiting one of these places, we will be happy to generate a letter for you. You may experience decreased sensation in the skin around your incision, but this usually resolves over time. Your knee may also be warmed at the touch. This is part of the natural healing process and will resolve over time. You may experience some stiffness with excessive bending or any time you introduce a new activity or increased amount of activity. If this occurs, it is recommended that you rest and ice for a couple of days. Kneeling can be uncomfortable but will not be harmful. A knee pad can be helpful with this discomfort. Do not be alarmed if you experience occasional soft clicking with some activities. This is a result of having metal and plastic as a knee versus soft tissue. Scripps' health mission is to support research. SCORE has a staff of 30 people and a lab devoted completely to orthopedic research, mainly total joint replacements. Colwell founded in 1985, we are entirely self-funded through philanthropy and grants. All 6 surgeons who perform total joint replacements at Green Hospital do research at SCORE. For more information on knee replacement surgery and published articles by your surgeon, you may visit the websites below. FAQs. What if I get sick before surgery? Call our office so we may discuss your symptoms. Unless you have a fever, are vomiting, or have diarrhea, you can typically proceed with surgery at your doctor's discretion. When will I get pain medication? We have a program called Meds to Beds where your prescribed medications will be delivered to your room prior to discharge. If you do not wish to enlist in this program, a written prescription will be provided to you at the time of discharge. Do I need to donate my own blood sugar prior to surgery? No, there is very little bleeding during the procedure and it is very unlikely that a transfusion will be needed. How long is the recovery period? Although the majority of recovery takes place in the first 4 to 6 weeks, the acute phase of recovery is approximately 3 months, and full recovery can take up to 1 year. But it is important to remember that recovery time is different for each patient. How long will my implant last? We are seeing implants last up to 25 years. When can I swim? We ask that you wait until your first postoperative visit so that the surgeon can assess your incision. Typically, 4 to 6 weeks after surgery, swimming is permitted. Can I have a disability placard? Yes, we offer temporary disability placards for use during the recovery period. You may request placard application from the nurse during your preoperative visit. This application can be redeemed at the DMV or AAA, for AAA members only. If you are seeking a permanent placard due to other ailments, please refer to your primary care doctor.